And I know my patients have too. And sometimes the change is very, very good, and sometimes it's kind of distressing. It's somebody who's been in the business. And my view of the medical world is pretty one-sided, obviously. Your view represents what your experiences have been and how you feel about things, but there are way more of you than there are me. So we've had these Wednesday night talks, and I just thought it would be helpful to get some perspective on some of the issues in medicine. Some things that you're concerned about, maybe that I'm concerned about, and maybe we walk away from here with a better understanding. That's what I hope to gain from this. Maybe we walk away with some resolve. Maybe there's something we do. Maybe there's a letter we write. Maybe you leave your name, email address, and I'll get you some names and email addresses of some of the people who represent us. Maybe if we want to be heard, we need to take some action. So with that as background, I guess before I just throw it open to questions, before we have total chaos here, I just want to give you just a brief, have you share ever so briefly a journey with me in my medical career, so you kind of know where I'm coming from. First, a couple of really good things that have occurred have been our ability to gather your information in one place, and that's called the electronic health record. When Dr. Dedman was practicing, he had the same experience that I did for many years, and that was that a patient would come in, and we'd have a stack of charts on the table between us. And I knew, and I think the patient knew, that if I was challenged to find something in there, there's no way in the world I could have done it. It was paper chaos. What's happened, and what you've all experienced when you go to the doctor, is that although he's somewhat distracted by the doggone computer screen, he can pretty much find where everything is. So the electronic medical record has become the best organized closet in the world. And you all benefit from that, and so do I. Unfortunately, the closet gets a little cluttered from time to time, and we have to work around things. But for the most part, it's predictable, and that's been a very good thing for all of us. The other things that have happened, I said there were two things, but a big umbrella is I'll call it the progress in the science of medicine, the changes that have occurred in medications that we have available, the techniques, surgeries that we have available are staggering for me. I'm always, if I step back to think about what I do on a day-to-day basis, I'm surprised how much we do for patients that we couldn't do when I started. When I was a third-year medical student, the way we would take care of a heart attack, for those people fortunate enough to make it to the hospital, we put them in a quiet, blue room with heavy drapes, and we would pipe in soft music and give them morphine. And that was pretty much it. And the mortality rate from a certain kind of heart attack, anterior wall heart attack, you probably heard the term widowmaker. It's a god-awful term, but people use it all the time. It's the LAD coronary artery. When that closes, it causes a large amount of heart muscle to be damaged, hence the widowmaker, or widower-maker, I guess. But in those days, we're talking about 1975, 1976, the mortality rate for that heart attack was 40%. And today, it's less than 5%. People get to the hospital and get treated, and the vast majority of them do well. So that experience, looking back at the mid-70s, see what we had then, see what we have now, it's been a really great thing for all of you, and for me as a practitioner. Along the way, there have been changes in how medicine has been practiced. And I guess that's kind of where I feel not necessarily isolated, but I don't share your perspective. And that's kind of what I was hoping to get tonight. See how you feel about medical care, Medicare perhaps. Whether you feel that you're getting a good deal, whether you feel if you have insurance, whether that's worked out well for you. I just kind of wanted to get an idea of the frustrations, barriers that people may face, or the victories that they may have had, probably on the telephone with a 1-800 number. So does anybody have any comments? Anything they want to offer? Bob?
I have one. One of the things that is of increasing concern is the number of bankruptcies in senior citizens, largely attributable to the cost of their expensive medications. I mean, you know, if you spend a few $100s a year, that's one thing. But if you're looking to spend $50,000 on one biologic agent, rheumatoid arthritis, that's another whole ballgame. And people are going bankrupt. And I'm talking about senior citizens, particularly, because of the high cost of the drugs.
Yeah, I think that's a point well taken. And I don't, you know, I'm not going to have any solutions for you, but I'm just going to jot down a few things you said, Bob, because there sometimes there's a certain catchword that'll trigger a thought. And when I say that, I think that our elected officials need to hear from folks like you. And senior citizens and bankruptcy and drug costs, all in the same sentence, could be pretty powerful. The test, of course, let me see if I can read this one.
Take it to a pharmacist.
That's pretty good.
That's good.
Take it to a pharmacist. Okay, you know, that's a point well taken, and it's something that there are people who are taking a look at some of these things. Larry, if I go forwards, can I go backwards?
Yep.
Not sure that any of these address drugs in particular. There are a lot of studies that have been done, and one of the, you take little bits and pieces from these, but one of them is that we're consuming less health care and it's costing more. So the actual consumption of health care by people has fallen by about 3% over the last few years, but the cost has gone up about 11%. And that's just from some of these stories in the Wall Street Journal, the Washington Post, and the New York Times. So that, Bob, the reason I point that out is it kind of speaks to your concern that the prices are steep for a lot of these things, and it's a situation where I think it's appropriate to examine why that is. And if more people speak up, because especially folks in your age group, they vote a lot. If people speak up about their concerns, maybe something will get done. So it's the kind of thing that it's definitely worth examining. The big pharma, people who make these drugs would tell you, they've got our research and development costs, and that's why things are so expensive, and there's probably validity to that. But it is worth posing the question. So,
can doctors speak up also?
well, you know, we can, but that's pretty interesting. When I started practice 35 years ago, doctors had a lot more of a voice. We had more influence through the AMA. The AMA used to be a real force, now not so much. Even state medical societies, county medical societies, now not so much. But, and it's interesting you bring that up because sometimes it's just the patient and me in the exam room, and we both feel kind of like we are powerless for some of these problems that come up. We can speak up as more and more physicians have become employed by hospital systems. They really don't have a forum anymore. There's not a way that they can, they're not speaking for their patients. A hospital administrator is now speaking for the doctor and the patient. So
And that's what happened here.
yeah, that's kind of what happened here. Yeah, we had we had the good fortune to have some really top flight cardiologists who wanted to practice like I did in the old days, and they took a flyer at it, and here we are. So, yeah. Any other questions?
I do. I'm
Yeah,
a
please.
case supervisor. So when the oncology, hematology was over on Valley,
Uh-huh.
they went separate like you guys. So when I first went there, when they first opened, they said, look at this place, state of the art, we charge less than the hospital. No. There is a YouTube video or there's an article in the paper, is it this year maybe? Anyway, a doctor, was my doctor, oncologist, had said that the hospital can charge from 20+% to 50+% more than their facility.
Mm-hmm. Right.
Now, how is that fair? And here's another question. So if we do call our congressman or whoever, do we have a plan? That's another thing, we need a plan because they're gonna ask us, so what do you want us to do? And that's our biggest thing. How can we, what way can we influence them by saying, we have some research done that if we do it this way, it's gonna save money, lives, I mean, Medicare, insurance, I mean, a benefit for everybody.
Mm-hmm. So it's a good point and a good question. I think that your observation or what you were told about an outpatient facility charging a lot less than the hospital is true. A hospital administrator would come back right away and say, well, we've got costs. You know, we've got the ICU to maintain, and the emergency room to maintain, and the operating rooms to maintain, and the cafeteria, and the custodial staff, the whole thing. So there would be a counter argument. Your question about what would we propose, and now that's a fair question, and I think the honest answer is, well, we're a long way from being able to come up with the solution. But it's reasonable to challenge your elected officials to come up with something that is going to save Medicare for the future. It's worthwhile to look at some of the proposals that are floating around. I think Medicare for All would be extremely expensive proposition and might imperil the Medicare we have now. You know, it's serving a lot of people very well. So I don't think, I'm telling you, I'm not the expert. I don't have the answers. But I think it's worth posing those questions, challenging them to come up with a solution. There will be some tough decisions. Eligibility age for Medicare, for one, may have to change. It's 65 now, and may have to go up. 66, 67, just like it is for what is it, Social Security. Is that going up? I don't even
Right.
know.
Yeah.
But it may have to go up in order to for some cost savings, things like that.
We can spend trillions of dollars to destroy people, but we can't help people with some money. I mean, it's called a budget. Let's look at what we need, what we can do. I get it, we need defense, but do we need, and we know there's some corruption out there. Wars are made to make money, we know that. And you see it all the time, I mean, they investigate, and even with you can say big pharma. Here's a good one. Well, I eat heart. I'm here because of chemotherapy and radiation damage my heart. Okay? I wish I wasn't here, but I am. I'm going to be a 27-year survivor. But I told them after I had all my chemo, radiation, I had a hard time breathing. It's a lot of damage your right lung. I was like, okay. So I lived with it. Finally, that's all I wanted to do was sleep. I was diagnosed immediately after someone became a concern. That was 25 years ago or so, 24 years ago. I mean, and I'm finding that even with chemotherapy, we're treating people, and I'm not the only one with stuff like this. We know what causes some of these problems. Are we looking at that?
You know, it's,
I mean, there's side effects from, I get it, I'm blessed, I'm alive. I'm not complaining. But it's very expensive to even be, I mean, I think, I just went on Medicare, permanently disabled. But like for chemo and any of that, you're responsible for 20% of your treatments now after Medicare takes. And if you think heart's expensive, try to treat cancer.
yeah. Yeah, you raised some good points, some tough ones, and I certainly don't have the answers. You're asking about side effects, and unquestionably there are side effects from some of those medications, and they know going into it that the heart is one of the innocent bystanders sometimes, and they will do tests to see if they can determine that, or spot that coming, but it's tough. And these are the discussions that you'll have, you know, with your doctor. They've given it a fancy name. We always used to do it, but they now call it shared decision making. And it's to talk about the pluses and the minuses, where you can make some gains and where you run the risk of having some losses. And it gets to be a very personal thing at that point. And hopefully you have a doctor who can work through it with you and help you make decisions. Yes, I think you probably had some pretty good help along the way, considering your timeline.
I do, yes. I've been blessed, like I said, but I don't know how to explain. But there are some things that we know work. We can put it on perspective. You know that this works, that doesn't work. I don't even know, even educating people more on heart vascular disease would be huge. Like this right here is awesome. I mean, I've learned a lot of different things that I didn't know about it. You know, well, I'm new to this heart thing too, but I mean, this is good for people to understand what can happen if you don't do these things. And maybe our government needs to educate people a little bit better too, what to do. I mean, there's lots of things. I mean, vaping, you buy something to kill yourself? I don't get it. They shouldn't even let that go.
It's a clash of philosophies, I think, sometimes, and it's when it comes to healthcare, you know, the guy who rides the motorcycle who doesn't wear a helmet, you know, when everybody sees that from time to time. It's not right, but it's the freedom that one person has and the potential burden that will be placed on society if he makes a wrong choice. Did you have a comment?
No, I'm sorry, I want to take this from the lofty issues of public policy.
Yeah.
I had a heart attack 20 years ago, and was treated at AMC. He's my cardiologist, and now you all made the decision to move from that facility to this facility, and I made the decision to all along.
Okay, good.
So, but specifically for me and for some other patients here, what changes can we expect from the decisions that you all made to become independent and open your own shop?
Well, in a sense, we're going back to our roots. I mean, we were not employees until 2011, so it's in the timeline in my practice, it's a relatively short period of time, so we're kind of going back to where we were. When it comes to a relationship with the hospital, if we put our patients' needs, concerns first, we generally wind up making the right decisions. So if our patients want to continue to be cared for at one of the Theta Care facilities, we'll take care of them there. Now that, I'm speaking from our perspective, that could change. I suppose they could do something unilaterally that would change that, but as long as we have privileges, and it's the medical staff that privileges doctors, it's not administrators. So as long as we have privileges at the Theta Care hospitals, we'll be able to take care of our patients there. So that's something that's that we're counting on, and as we talk to our patients about it, if they want to stay at the Theta Care facility, we're sure going to provide that care. So I guess I can't look much further into the future for us. We're trying to get our phones answered and stuff like that, So we're experiencing the growing pains of new business and trying to work through those and provide service. That's our number one goal. And have people keep a good sense of humor throughout if they can.
The question has come up at a couple of these previous talk sessions about, okay, if I've got a heart problem and I go to the emergency room on Saturday night and they say, well, Dr. So-and-so is going to see you. He said, I want to see my cardiologist. In my case, there's nothing. See, and I want to see him. They have to honor that.
Yes, I'm glad you brought that up.
But that's come up several of these sessions.
Yeah.
Yeah.
You have a lot of power as the patient. I mean, you're legally, ethically, and you can exercise that. There is a tendency for the patient to be told what's going to happen, and you speak up. It's it's your right to say who you want your doctor to be, and you just have to let them know. I think in the emergency room especially, things happen fast. It's possible that you could get treated without necessarily understanding that you do have choices, but you need to just keep that in mind and exercise your options.
Now, if there's an acute emergency, let's say cardiac arrest or whatever, then whoever's there has got to take care of it.
Sure.
But if there's a time for a choice to be made,
Right.
then patients need to speak up.
Absolutely, yeah. And if you were admitted under another service, and the next day came, you realized, oh, this isn't what I wanted. Again, you have the choice. You can say, I'd like to make the switch. We hope that you'll always look on us favorably, and you'll want to make the switch for us, and we'll be there.
It's also true when you visit your family physician.
Right.
And they may be suggesting you get referred to a specialist, a cardiologist, or orthopedic surgeon, or whoever. You have the choice of who you're going to go see, regardless of what they may say to you.
Anything else that's on your mind?
I think one other thing about, you mentioned the electronic medical record.
Mm-hmm.
I think one of there are problems with it, but I think one of the good things is that they don't have, the pharmacist doesn't have to try to read my handwriting.
That's true. That's come a long way.
Yeah, the electronic prescription is probably one of the best features and less prone to error.
No question about that.
Yeah.
And that came a long way in a period of really a few years that was enacted. So that was really good progress.
The other thing is the computer, now with computer systems, pharmacists can interact and check the medications for drug interactions, and also can pick up prescription shoppers.
Yeah, that's
You know, they
true.
want the sleeping pills, the tranquilizers, so they can peddle them on the street.
Yep,
And that's been a great help.
it has, there's no question about that. And getting back to your point about how we're gonna know about some of the drug interactions and problems that, different therapies, they might collide in terms of the action in the human body, there's a chance that we may learn a lot more from the electronic medical record. In the history of medicine, a lot of our treatment has been based on what we call randomized trials. You take two groups of patients, one you give them the sugar pill, the other you give them the real treatment, and you look at the outcomes. And that's a commendable experiment, but it's hard to do. It's hard to get enough people enrolled. It's hard to define a study population that will have general applicability. I mean, if you look at trials from the 80s and 90s, most of them were men. They didn't have a lot of women represented. There was an age cutoff. They didn't have people much past the age of 60 or 70. There were often ethnic biases, so that maybe Native Americans, blacks, Asians might not be represented adequately. So while those trials were good, they were kind of limited. A lot of medicine it's all about subsets, who we actually treat. Well, if you have large registries, which you can accumulate through the electronic health record, you can learn a bit more just by the power of the numbers. When you have hundreds of thousands of patients, you can learn more than you could, say, with that randomized controlled trial that had 50 people in this group and 50 people in that group. So potential benefit there. Yes,
So
please.
as of right now, it's just the physicians that can get the electronic records, not the nursing staff, correct?
Oh, yeah. Well, actually, that's a good point. And I don't want to be a rabble-rouser. I don't want you to get that opinion. But it is kind of unfortunate. This is your record. This is your health information. And it is managed, that information is managed by a few large companies. Epic is a very powerful electronic health record. There's some others, Cerner, some others that are in the business. But when those records or those systems, those closets, if you will, are purchased by a hospital, then the hospital gets the right to decide how to use that information. And we don't think that's right. I mean, we think it's your information. You should be able to decide who sees it, who adds to the database.
So
And
you
right
have-
now, it's not that way. So in answer to your question,
Even though we sign the release records for you, the nursing staff can't get those records, only the physicians, is that right?
that's right. The nurses can do it, only the physicians. The difficulty that poses is when we're trying to do something for you quickly, they can't get into your old Epic record. Like if it's to look up a prescription or a lab test, they have to track us down and have us do it. So it's cumbersome.
So will that be coming, that, I mean, are you is it a possibility? Is that something?
How do you
being-
change that?
Yeah, there you go. There you go.
Larry, you want to try to feel that one?
Well, as Rob said, it's unfortunate that, there are instances, one here locally, where a health system purchased the product that houses the data, and then has decided who can have access to it. Well, I suspect if it asked the community what they would want, the community would say, we would want everyone to have access to it. Because that would be for the betterment of all. But that's not, it's unfortunately as much a political issue, more so than it is that decision being made on what's best for the patient. And it's unfortunate. But, what option we're pursuing is, can we get access to Epic through another source that they care. And So we're trying to figure out what those options might be. Now, we installed an electronic health record in this building. It happens to be called GEMS. There's a number of them out there. And probably by the end of our first year, that will be fully populated with all the patients we've seen. And access to Epic becomes a little less problematic, but still, the fact that the majority of the community, the rest of the medical community, is using Epic, and we can't easily see what they're doing and they can't easily see what us doing, doesn't make a whole lot of sense to us. But we're not the first group that has been kicked off of Epic, and we're probably not going to be the last. You know, and you know, we hope that at some point wiser heads will prevail at the health system and realize that, or the community will learn some of the realities, and the community will start to say, hey, you know, this is a community-owned health system. You need to be working on behalf of the community, because SaveCare is owned by the community. You know, I think the question is it really being representative of the community? And
I'll give you a tiny
So,
example.
okay, our primary physicians are with Beta, but we have you for cardiologists. So is it going to be the same problem, our records from you, that our primary physicians will have the same problem seeing, or how, does that go both ways?
Yes, it does. I mean, people have to make an effort. It's old-time technology. It's called a fax machine. And so our records get faxed over to DataCare, and they get them in there. I mean, I've seen them in the Epic record. So it's working, but it requires a lot of effort. A small example today, I admitted somebody from the clinic. So I called Julie and Dr. Ackle, they're working over in the hospital. They're there all the time. You know, they're fully staffed during the day, and told them this gentleman was coming over, and about an hour later his labs came back, and I was in the middle of several other things, and they were on my desk, and I looked at them and I realized if I don't call and tell them what the lab showed, they're going to repeat them.
Right.
And that's just not right. So I had
So,
to
so
find.
you do have that situation, if we go into the emergency room, they can't actually see our records through you then, right?
Right.
Test and
There
things
might
like
be a
that
delay.
through you?
There might be a delay. If it's on a
Right,
weekend
okay.
and they can't get in, you know,
Okay.
they can't have somebody fax it there.
Okay,
We don't have to wait till Monday morning.
okay.
But everybody's got to be hustling a little harder. Now, we happen to be in the hustling mode right now, so it's all right. But I can't say that there'll be reciprocity. You know, that it's not always that that they're eager to help us out. In fact, when we order tests over there or set up a cab, we have to jump through a lot of hoops, and we were upset and indignant about that at first. Now we're just upset and indignant.
Well, question you raised, now for example, my personal private doctor is Dr. Balls. And Dr. Melke is my cardiologist. So I came over here and I signed a release to get my record, my cardiology
Right.
records, because I've had some other cardiac exams, so that Doug could have access to those. Then I had a couple of tests done here, and I got a call from Walls, said, hey, I saw your blah, 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 you know, your vascular screen and so on. So there is some communication, but I think the important thing here is, and I sent a note to the powers that be, whoever that is up in the cloud at ThedaCare, and said, I want copies of my cardiac stuff sent to Dr. Milky. But understand that Balls is still my primary physician.
Right.
So my general medical record should still stay at ThedaCare on Epic.
Right,
Now that's a little bit of hustle bustle. But for the time being, that's kind of the way
Right.
you have to do it. But speak up,
Yeah.
you know, don't be hesitant. You know, doctors bark a lot, but they don't, most of them don't bite.
Well, they're not usually in control of those things.
Yeah, that's the case, that's for sure. Okay, anything from the medical side you want to hear about, the cardiology side? I can speak with a little bit more confidence about those things.
So what's your expertise?
I'm a general cardiologist. That means I talk to people and listen carefully, because 85% of diagnosis springs from the patient's lips. And this is something I feel pretty passionately about, and I'll just share it with you because I think it's a lost art. And I'm concerned for the future doctors, not my current colleagues, they're pretty much steeped in medical tradition, but future doctors, and for you, the patient, because there is nuance, subtlety to every patient's story. You're not exactly like any other guy. And when you look at the medical record, if there's not some effort put forth by a physician, every patient looks the same. When they ask you those little yes/no questions, they all go in the computer with the same amount of clicks, and you all look like you've got the same problem list and the same set of symptoms. So, you asked me what I do, I did the same thing that Bob did. When I sit and talk to patients, I would use 4 words that Medicare will never pay for. And then what happened? Because when you tell me your story, I have to pick away at it. I have to chip away at it to get it right. And to keep asking, what's next? What's happened? What came on after that? That's really important. Example. A 25-year-old woman passes out in the grocery store. And she goes to the emergency room. Well, there are a lot of things that you can do for somebody who passes out. A lot of testing that can be done. But the most important thing would be to ask her about the circumstances. And if you ask her questions carefully, you would learn that she had gotten up in a hurry that morning. She hadn't had anything to eat or drink. She has a history of passing out when somebody tells her something gruesome, or she sees something that's the sight of blood, getting her blood drawn, a needle stick. If you talk to her about those things and consider her age, just look at a basic EKG, you can be pretty confident, and you learn that she had some sweating and nausea and a feeling of, whoa, this is just not right, here I go again. That's called a vasovagal faint, and it's common in young people. That's why guys pass out in a wedding, on a hot day, they're standing there with their legs locked. And that person, the appropriate evaluation for them, after you've gotten this Sherlock Holmes story out of her, and you grilled her thoroughly, and you're pretty confident that you've gotten the right information, she might just walk out of there with an EKG and some instructions about not getting dehydrated and making sure you don't let your blood pressure fall. And that would be the right thing to do for that 25-year-old woman with a low risk of an underlying heart problem. She didn't have a murmur on exam, her EKG was okay, boom. You sternly tell her to do the right thing for her health. Stay hydrated and be aware of your risk. Take a 75-year-old man who's working on his car and he passes out, and you find out that he'd had some chest pain a week before, and when he passed out, he went down like a ton of bricks and he had no warning at all. That's a completely different story. And so the point is that if you turn this into a succession of yes/no questions and you lose the texture of the story, then medicine has lost something. people are going to be cared for in sort of a generic way. And that's too bad. Diagnoses it won't be missed, it'll just take you longer to get there. And you'll have to wade through a lot more tests, be more expensive. And that's basically what I do. I try to do detective work. I don't make a concerted effort to keep it cheap. I'll test when necessary, but I want to be able to answer this question. Anytime you order a test, what are you going to do with the result? Because that's the way it ought to be done. Now, too often there's sort of a shotgun approach. Oh, if you passed out, we're going to do this test, this test, this test, and this test. And that's not the way it needs to be done. So along the way, in addition to talking to people, I read echocardiograms, do stress tests, people in the hospital, that sort of thing. I used to do cardiac catheterization, used to put pacemakers in, but we have some younger people in our group who do a fine job with those, and I dare say have a slightly better reaction time than I do, slightly better motor skills, ever so slightly, and so they're the ones who should be doing those procedures. In 2 or 3 generations, there'll be a 14-year-old at a console who will be running the switches, and it'll all be remote. Everybody will get their stuff done with a Da Vinci robot. So it'll evolve, but for right now, got to let the younger people with slightly better motor skills do their thing. So I don't do angioplasty or stenting or that sort of thing. Yes?
Oh, I'm just gonna throw a question at you. So if somebody has elevated cholesterol and LDL levels, but they have a 0 calcium score, is that unusual?
That depends on the age. We don't expect people.
Like 50?
Okay, that's pretty young. Male or female?
Male.
Female?
Male, male.
Male, okay. It's not a surprise that somebody with a high LDL cholesterol would have a calcium score of 0 at age 50. What you want to do, though, is everything you can to lower the LDL and keep the plaque from forming.
So would you recommend that they go on medication?
It depends on the rest of the profile, because all these risks are additive. So,
Well, he's got it in his genes.
Okay.
This is actually her husband.
okay,
And she actually just had a heart attack herself at 44 years old. But her husband has it in his genes.
Uh-huh.
And so she had him have a calcium score because she was worried about him. And it came back 0. But his cholesterol and his triglycerides, I mean, they're elevated, but the score was 0. And it was like, she's like, okay, this isn't helping me.
Yeah.
Now I'm not going to convince him to go on medication, you know?
He needs to be reminded that it's not a warranty card. I mean, it's a snapshot. It's how things are right now. And plaques don't calcify until they've been there for a while. So he could have soft plaque. The thing that you want to do is invest in your future. I mean, all this business about 5-year risk or 10-year risk, it's not very applicable to a guy who's 50. I mean, he wants 40-year risk. That's what he's looking at. So, it gets back to the choices that we all make, and we have to be the patient's advocate. We can't be a scold. And some of our patients will look at us with a twinkle in their eyes and say, Doc, nobody makes it off the planet alive. I'm going to enjoy what I'm doing right now. And some people, when they deliver that message in that cheery way, it's really hard to talk them out of that position. And maybe they've got a point for them, maybe that works.
So do you suggest getting like another calcium score in say 5 years to see if it...
That would be a reasonable
Do you
thing
know
to
what I mean?
do. Yeah, that would be a reasonable
If he
thing.
doesn't go on medication
Yeah.
and his cholesterol stays high,
Yeah.
you think 5 years is a good time or?
That would be a reasonable time frame, yeah. The calcium score has very low radiation. It's probably less than a plane ride across the country in terms of the amount of radiation you would get with it. So it's a 5-year time frame is reasonable.
Okay.
regular exercise, the arteries love that exercise.
Good luck on
In
that.
in our world, in our culture, almost everything, every day-to-day experience makes us coronary arteries just squinch right down, constrict. That's the wrong thing. These are conduits or supply lines. Constriction is bad. Exercise relaxes them. So when they talk about, are you guys familiar with 150 minutes of exercise a week? Usually it's 30 minutes,
5 days a week, right?
We all subscribe to that. We recommend that across the board.
So, Doctor, 2 guys just died 3-4 days ago in an Ironman in Madison. And they were the government good in exercise. They probably had a heart situation. And what do you think that was about?
Well, do you remember Jim Fix?
Sure.
Okay, the complete book of running. Well, he had a similar situation. He died running. And he had a bad family history and a bad cholesterol profile, but he thought he could exercise enough to overcome his genetic predisposition to this. And he just kept pushing. And I imagine the guys in the Ironman had a predisposition to this. When the arteries narrow, they do it slowly, but sometimes a plaque can tear or rupture, and you can go from like a 25% narrowing, and if the plaque is disrupted, a clot starts to form. A clot can form quickly in a matter of minutes. So you can go from a 25% narrowing, which doesn't limit flow at all, to totally closed. And that's, it's kind of a biological accident, but it can occur.
So they should have known that?
They may have known that. They may have known they had a tendency or a problem. And their age would be important as well. Somebody in our age group was going to start doing something crazy like that, you'd want them to get checked out first.
One of the fellows was, I presume a young man, he had young children.
It's possible he would have had a different kind of a problem. The commonest cause of sudden death in young athletes is something called hypertrophic cardiomyopathy, with an abnormal thickening of the heart muscle, and abnormal heart rhythms go along with that. So you can be fine 1 minute and then have an abnormal heart rhythm and be down on the ground the next. It's a cardiac arrest situation. That's unrelated to a blockage problem. It's an abnormal heart rhythm situation.
What do you call it when the athletes get hit in the chest?
Oh, commotio cordis,
Yeah, that's it.
for Latin scholars.
Doctor, I just transferred here and saw one of your physicians once, but he's not going to be here, he's retired. So therefore I've got to choose another one. And there's a whole bunch of you here. What rules should I use to try to choose which doctor I should go to?
Yeah.
That are here.
Yeah.
Those we've heard are all good, personality-wise, yourself included. But who should I?
Well, I think there are little bios that are available. It depends on the nature of your problem. If it's an electrical problem, you'd probably want to have one of the two electrophysiology doctors see you, either Dr. Marion or Dr. Sal. For anything else, any one of us could take care of your, if it was a coronary artery problem or a valve problem or a cardiomyopathy problem.
AFib is what I
Atrial fib? Okay, so the people who are the experts in atrial fib are the electrophysiologists, Dr. Marion and Dr. Sal. Now they're more focused on procedural approaches to atrial fib. The rest of us can manage atrial fib with the medications, but if there was any procedure in your future,
Would you refer him? You would refer them.
you bet, sure.
The two you said were the experts are Dr. Jim Mariano
Yeah.
and Dr.
Lee Zhao.
He is the guy who spoke last week,
No,
No.
Okay. You said-
It was
Couple of weeks
the
ago.
time before last, I think, before
Yeah.
Chapman. Chapman
That
was
was
last.
after.
Chapman,
I am.
ZHOU.
Dr. Zoll was 2 speeches ago, Dr. Mariano was 2 speeches coming up.
Okay, all right.
I've got atrial fibrillation. Doug Melky's my cardiologist. He's a general cardiologist. And as long as he's got me on one medication, and as long as I'm doing okay, that's all I need. Now, if I start having problems, serious problems, and need a procedure like ablation of the atrium or something like that to interrupt the abnormal electrical system, that's when I would go to one of the
Sure,
electrophysiologists.
but if I'm gonna switch to something, why don't I switch to whoever's the expert? It sounds to me, they're two.
Well, you know, that's fallacious reasoning.
Okay?
I'm sorry. But if you have atrial fibrillation, you see a general cardiologist, and you're doing okay. The specialists are for the electricians are the specialists for people that have serious problems.
See, atrial fib is a funny thing. It has its own timeline. All right, what I mean, first of all, atrial fibrillation is an electrical abnormality. The heart has two functions. One's electrical and the other's mechanical. So every heartbeat starts with your own pacemaker, an electrical impulse. It fires and sends an organized signal out over first the top chambers of the heart. And the message is squeeze, because the chambers have to be told to contract. So the atria squeeze, all the cells squeeze together, and they propel blood from the upper chambers down into the lower chambers, the ventricles. So the ventricles fill up, and about the time they're full, that same electrical signal that started up in the sinus node now arrives at the ventricles with the same message. Squeeze. So it literally is lub-dub, over and over again. It's this wonderful monotony. That's why you're not aware of it. It's like breathing. So lub-dub. Then one day your atria goes haywire. It quits lubbing. It just starts to wiggle, fibrillate. It's onomatopoeia. It fibrillates, and there are a couple of consequences of that. One is the blood flow in the atrium becomes more sluggish, and a clot could form spontaneously. And that's why people get put on anticoagulation to keep that from happening. The second consequence is the ventricles have lost their band leader. They're looking up to that electrical signal, and all they see is chaos. So they tend to go fast and irregular. And that's the part that gets people in. And when they first have this, they're miserable with it. Fix me, fix me, fix me. That's what we usually hear from them. And then as time goes by, and atrial fibrillation can come and go, but over time it tends to come and stay. And a lot of people will get very used to it, completely unaware of it. So that sensation that was so troublesome to begin with is now quite tolerable. That's how it is for many, many people. Not for everyone, though. Some people remain very symptomatic when they're in atrial fib, and then they wind up getting that ablation procedure. If they're not so very symptomatic, or they can be controlled with an additional medicine, then they just kind of perk along with medications. So it's a situation where you have to match the treatment to the patient's needs. Not everybody who has atrial fib gets an ablation. That wouldn't be right. You look pretty skeptical.
No, no.
Okay, I've got one more
Yeah.
general question on the
Sure.
calcium score. So if someone has a calcium score, would you recommend cholesterol med? Or is there a certain number, or is it dependent upon the artery that you have it in?
Those are great questions. Calcium score is an interesting test because it tells you what's going on right now. It tells you have plaque and it's got some calcium in it. But the main thing is it says you got plaque. So what you do about that kind of depends on your age, your other risk factors. But in general, I would nudge people toward a statin, toward trying a cholesterol-lowering medicine. Now, a lot of people don't like the idea of statins, just because they've heard so much about it,
Right.
about them. A lot of people really have bona fide aches
Can't
and
take 'em,
pains
right,
with statins, and
right.
they can't take them.
Right.
So on the horizon, getting back to our damn expensive medicines, there are new classes of medicines that don't do what the statins do in terms of muscle aches and pains. They're injectable, you get either once every 2 weeks or even once a month. And a little bit further on the horizon, there's some medicines you might take every 6 months. That's a possibility to lower the cholesterol. So I think that if you're forming plaque and you're young, you want to do what you can to inhibit that tendency.
Well, probably even older though, correct?
Probably what?
Even if you're older though, correct? I mean,
Now, that's a real interesting situation, because there's evidence that people in their 70s and 80s do benefit from being on a statin. Sometimes people say, why would you put a guy who's 80 on a statin? Well, there's evidence that somebody who's 80 would benefit in terms of, what does benefit? Man,
92,
yeah, there you go. Benefit in terms
and that's
of
probably why.
fewer strokes, fewer heart attacks, less time in the hospital, better outcomes in general. So, yeah, the calcium score, you know, you guys know about Framingham, Massachusetts, the Framingham study. There are 5,500 people in that study. I'll bet you there have been over 10,000 medical papers written about the Framingham study, Framingham, Massachusetts. And those people have been followed over time, and they identified risk factors for vascular problems, for heart attack. And the 3 you couldn't do anything about: your age, your gender, and your family history. And then there were 4 that you could: smoking, high blood pressure, diabetes, and cholesterol. So over the years, doctors have tried to sort of figure out who gets treatment based on a person's risk score from the Framingham study. And that's reading the tea leaves. That's trying to make an educated guess about somebody's risk of forming plaques. And now we have a test, a calcium score, that tells you are having a problem, do something about it. So for us, it helps persuade people that it's the right thing to do.
Well, I went and got it because I wanted him to, because, well, we both have it in our genes.
Yeah.
But I've always had good cholesterol. My good cholesterol is like over 100.
Oh, that's great.
Yeah, but, so I had the calcium score, and I've got it in my Widowmaker calcium.
Well,
But no other symptom. If I wouldn't have had that calcium score, I never would have known it.
Yeah. Well, everybody's story is a little bit different, and
Yeah,
it's,
that's why, yeah.
yeah. And so now it's like an early warning system for you. Any symptom that you get that's new, it's above the waist, you're going to be thinking, could this be a significant symptom?
I just had blood work today, and they were just blown away, my numbers, how good they are. They kept saying they're phenomenal, but I know because of the calcium score
Yeah.
that doesn't mean everything.
It's helpful in many instances. Any other medical things? I'm on much surer footing with medical than I am with political, social, moral, ethical.
Yeah.
There are a number of people who have high calcium scores, and I'm one of them. My calcium scores, I did it last week, 1,600.
Okay.
But there's no evidence of obstruction. And
Well,
Lynn
listen-
told me, he said that a lot of the people with high scores, the calcium is external, so that doesn't obstruct the vessels.
Yeah, and that's right. And we cannot tell. Is there a Sharpie in here? We can't really tell. Oh yeah. From the calcium score about the flow through the artery. I always tell patients it's like the river and the river bank. Okay. So what is a coronary artery but a conduit? Okay? This is the flow. This is the river. Right there. The trouble starts on the river bank. That's where the calcium gets deposited, in the wall of the artery. So there's a lining in the artery called the endothelium. That's nice and slippery, so the blood cells slide over that. And the plaque starts to form right under that lining. Okay, and initially, when the plaque forms, the artery gets remodeled in this direction. It actually gets bigger in diameter. No problem with the river. But eventually, the plaque will go this way. I shouldn't say it will go that way. It may go that way. And so then the river does get dammed up, and that's what the problem is. When the river gets dammed up or blocked completely, that's when you get trouble. People can get a situation where they have lots and lots of calcium that behaves itself. It never dams up the river. And then they can have a calcium score of 1600 or 2200 and no problem with the flow. So that's how that works. It's one of the variations in biology. It's humbling to us all. We think we know everything and then we don't. So the calcium scores, as a lot of our patients who come in with a very high score are very excited. They've never had a symptom and they're very excited, and then we have to go through the steps to look at the river, see if there's a problem with it being dammed up. So, but that's how somebody could be in Bob's situation where you'd have a high score and no blockage. It does happen. It's a bit more likely to have a blockage the higher your score goes. That's why they will give you a certain 5 or 10 year risk based on your calcium score. Yes, sir.
About 10 years ago, I had stents put in here, and you put me on Diavan and Lipitor.
Okay.
Well, somehow over the last 10 years, changed the doctors and one thing or another, they changed my medication to the cheaper drugs. And I take my blood pressure every day, and I noticed that it's harder to keep my blood pressure in check.
Okay.
With the lower cost drugs.
It may be just a question of quantity. Sometimes in making that conversion from one to the other, and then milligram, did you put on losartan?
Yeah.
Okay. So Diavan, Valsartan, typically
I didn't have any trouble with it.
it gets prescribed in units of 80, being 80, 160, 320. Losartan can get prescribed in units of increments of 50, 50, 100, 150. So sometimes when you make that switch, you're getting relatively less medication, and you just need a higher dose. Then sometimes people have different needs as time goes by. You just need more medicine.
So my salt consumption will make it vary 15 or 20 points. You gotta go on a no salt.
Some people are very salt sensitive, others not so much. It's very reasonable to try to limit your sodium as much as you can. But checking the blood pressure, that's key. That really helps us. If you come to the office, we get one number for that day. If you check your vital signs at home, people log. The log is key. Write down the date, the time of day, the heart rate, the blood pressure. And if you come in with 20 numbers, that's data. That's good. We can make a lot more decisions with that kind of information. So we like that. We like our high blood pressure patients who keep a log. Makes our job so much easier. Yes?
So I had a heart attack in February. No warning. I mean, I did have a little bit of high blood pressure for since May before that. So almost a year. How do I know, do you just assume that since I'm on the statins and that there's not going to be any more buildup? Or how do I, because they don't check any of that now, and do I wait till I have another heart attack, to
Yeah.
find out that there's buildup, or how do you keep track, do you just assume that it's okay with being on the medication?
There is, you do all you can. I mean, you get the regular exercise in, make sure your blood pressure is well controlled. Do you have any blood sugar problems?
Nope.
Okay.
No
Thank you.
diabetic, no
Not a
smoking,
smoker.
nothing.
All right.
I mean, nothing, my cholesterol's not even, it's pretty good. It's
Yeah.
just barely it's kind of on the border. And they've never even thought twice about it until this happened. And
Right.
so I had nothing to suggest that, so do we just assume that the cholesterol medicine, even though I didn't really have high cholesterol, is going to be enough to keep it from happening again? Or how do you know until it happens again?
You never know for sure. It's worthwhile. I mean, and I say you never know for sure. In today's world with our technology, it's not feasible to give you an answer about how your arteries are on a
Right.
year-to-year basis.
Okay.
That exercise is not only good for your arteries, it's a great early warning system. I mean, if you're exercising vigorously 5 days a week and all of a sudden one day you hit the wall, that's a red flag. And I'll give you an example of how powerful a predictor that is. In the 1970s, Duke University published a large trial looking at treadmill performance in people with coronary disease. The single best predictor of how a person with coronary disease would do over time was how long they could walk on the treadmill. It's called the Duke Treadmill Score. We use it today.
Mm-hmm.
And so if you've got great exercise tolerance, that's a good predictor for your future. It just means that your heart's happy with the blood flow that it has. And we don't know if you have a 40% or a 50% or 60% narrowing, but we can be very reassured by great exercise tolerance with freedom from symptoms. So a lot of people say, when are you going to do the next stress test, Doc?
Right.
And the answer to that is, we'll talk about it. You can't make a blanket recommendation for when to do a stress test. It depends on the individual.
So if they say fit the 30 minutes 5 days a week, if I walk an hour and a half, 7 days a week, I mean, does that make it better, or does that really not make a difference?
There's thought to be kind of a threshold for that 150 minutes. You ask a great question, and the exercise physiologists come up with a different story every few years. We used to poo-poo any kind of weight training. Well, it turns out working out with light weights is good. So I think you just have to keep track of it, and that's why you go see your doctor periodically, is to touch base. I think that, and challenge your doctor. What's the latest and greatest, and then you read yourself, because the internet has just opened up all kinds of possibilities for you. I mean, you can Google things. All the doctors use Google like crazy because it's so fast. I mean, it gets you an answer right now. You just have to know how to ask the question. Yeah, Dr. Google, my main man.
It's nice that you're open to
For
it.
that,
Sorry.
she should be eating food-wise.
Oh, yeah,
Oh yeah, the diet controversy just goes on and on and on and on. I mean, eggs, bad, good. Coffee, bad, good. Nuts, mostly good. So the key thing, I think, is kind of what the scale tells you. When if you can lose weight if you're overweight, or maintain weight if you're normal body weight, you're doing okay. It has been shown that people who lose weight with the old-fashioned American Heart Association low-fat diet would have the same reduction in their cholesterol as people who lost weight with a high-fat Atkins diet. Okay, so losing weight was the effective way to have a good impact on your cholesterol. It really didn't matter how you did it.
Doctor, I'm trying to get my glucose number down. Is there any point which you shouldn't go below?
For the glucose?
Yeah, can you get too low?
Oh yeah, the glucose will fluctuate, like blood pressure. Glucose fluctuates throughout the day, and are you going glucose lowering medications?
No.
Okay, you're probably all right then, but in answer to your question, you could get your blood sugar too low. For somebody who's used to a blood sugar, in the 120 range, if your blood sugar got down to 60, you'd feel it, you'd know that.
So if you got down to 80, is that a problem?
Probably not. So I don't know what time it is, but I'm respectful of your time. If somebody needs to leave, feel free to saddle on out of here. And if somebody if you want to stay and ask specific questions, I'm happy to try to field those for you.
You got anyone?
I get it.
Thank you very much.
You bet. Thanks for coming.